So many people are in the waiting room. We can allow them, huh?
9 o'clock.
10.
Sorry, 10.
9:59.
Super visible. Shilpa, shall I start?
Good.
Yes, sir.
Morning, warm welcome to online anesthesia. Today program is on pain medicine. So for that we have an expert and pioneer in pain medicine, Dr. Karthik. Today's topic is update in cancer pain. Today's session is coordinated by Dr. Rajesh Prakash. Over to you, sir.
Good morning, sir, and good morning, one and all. Today we have a different session in our online anesthesia teaching program, pain management, cancer pain management and update. The topic will be given by Dr. Karthik Natarajan, who is senior consultant pain physician from Chennai, Synapse Pain and Spine Clinic. A good friend of mine. I know him for long days, for nearly 18 years I know him, and he had left anesthesiology nearly 14 years back. He left anesthesia and is practicing only pain medicine for past 14 years, and the man who had taken up pain medicine into a different level in India. And if I remember correctly, long back he had cleared that FIPP exam when India had only 4 or 5 people who have cleared FIPP exam. And the man who had changed the pain practice, especially in South India. And he's a very good teacher, and he always promotes the juniors to come up. Right from the college days when I know him, he's a very good senior in anesthesiology and also in pain medicine. He promotes all the juniors to come up, and he's running a teaching program too, creating a lot of pain physicians in India, and he's a faculty in very well-known conferences, both national and international level. And is a teaching faculty in Natarajan Pain Clinic, which is a pioneer for pain medicine in India. And welcome, Karthik, for this session. And over to you, Karthik, for this session.
Good morning to all of you. Thank you very much for inviting me to the online anesthesia program. Special thanks to Dr. Rajesh, Jeyaprakash, Dr. Edward Johnson, Dr. Kripakaran, and the forum and other members for inviting me. So today, my topic is cancer pain management. Right? Now, whenever we talk about cancer pain management, one of the things that we discuss is how we are going to treat patients with cancer. Now, along with cancer, one of my intentions is to also increase awareness about pain management itself. Now, a lot of young pain physicians are watching. Can you see my slides, please?
Yes, sir.
Yes.
Yeah. So a lot of young anesthesia postgraduates are watching. So one of it is also to create awareness about pain management and also to create interest. So people from anesthesia background can consider thank you very much pain for medicine as one of the branches in which they can specialize in or super specialize in. So just like after anesthesia, you can go on to become a cardiac anesthetist or critical care or neuroanesthetist. Pain management is one of the avenues that you should consider. Earlier, we were struggling to get good quality training programs and educations and fellowships. Now, The training programs are available both in India and abroad. So it is something that you can consider as a specialization or super specialization after anesthesia. Now, I do a bit of musculoskeletal, sports injuries, and chronic pain practice. So my pain clinic is in Chennai. So I do run a program where we treat patients with spine problems, joint problems, orthopedic. We also do regenerative medicine. We do a little bit of endoscopic spine as well. And this includes cancer pain treatment as well. Now, the truth of the matter is it's a team work, right? So we work as a team. This includes pain physicians. This includes orthopedicians. This includes physical medicine, rehab, psychologists. This includes everybody. Now, regarding cancer pain, now in my practice, cancer pain management is about, let's say, about 15 to 20%. Now, when I say cancer pain, I'm talking about treating patients with cancer pain. I'm talking about pain interventions and supportive care. I'm not today going too much into what is almost hardcore palliative medicine. So I'm going to be concentrating more on pain and its treatment. Right? Now, we do see a lot of patients with cancer pain. And data shows that almost 55 to 60% of patients with cancer have some sort of pain. So whenever we say chronic pain, so we're saying about a patient who's having pain which is beyond a duration of 3 months. So 3 months is the cutoff. Anything beyond 3 months is chronic pain, right? So the patients with cancer require support in multiple levels, right? So during the time of cancer, the cancer cells itself can stretch the tissue, can stretch the fascia. This can cause pain. Second is they can impinge on nerves that are surrounding. That can cause neuropathic pain. Third, cancer treatment itself can cause a lot of cancer pain. We all know post-surgery, these patients have cancer pain. When I say post-surgery, it's oncology surgery. Post-chemotherapy, we know there is an entity called chemotherapy-induced neuropathy. And obviously, whenever we talk about radiation, radiation can cause adhesions and inflammation in the surrounding tissue. Radiation-induced proctitis, radiation-induced colitis, these are things that we do see. And sometimes we also have to treat the possible side effects that may come because of the treatment. So we are looking at a whole spectrum of conditions here. Now, if you talk about the incidence of chronic pain in patients undergoing treatment for cancer, we are looking at a data of around 55%. And patients with advanced cancer, the incidence of pain is about 66%. So this is a huge amount. So ideally, whenever we talk about cancer pain, you want to be working in conjunction with the medical radiation oncologist, so you know what is happening. So you want to be meeting the consultant who's your primary consultant. So you want to be discussing with the medical, surgical, and radiation oncologist. A lot of times cancer hospitals also have what is called as a tumor board meeting. So tumor board meetings usually are done once in a week. So you do have a chat with them and tell them what each patient is happening. If there is a difficult patient, let's say there is a metastasis sitting in the L3 vertebra, I may ask the radiation oncologist to see, can you do a radiation for that or something like that. So if you are working as a team, the results are better. Now, whenever we talk about pain in cancer, I told you various reasons are possible, but the most common pathophysiology in cancer pain, if you look at it at the microscopic level, is the cancer cells are undergoing division at a very rapid rate. The mitosis is happening very fast. Now, each organ has got its own blood supply, but you have an organ here which, because of cancer, is multiplying at a very fast level. So what is happening is you are having an organ which is multiplying fast, but it does not have blood supply. So at the most core level, the pathophysiology is ischemia. So tissue ischemia seems to be one of the reasons why the patients are having pain in cancer. And that's why whenever we do blocks there are two types of blocks. One is somatic block, one is sympathetic block. Somatic block is you just block the sensory supply to the organ. Sympathetic block is you block the sympathetic supply. Along with that, the sympathetic supply also causes vasodilation. Because the pathophysiology is ischemia, the sympathetic blocks tend to do better in cancer pain management. Right. So the type of pain that you're going to see, one is nociceptive and there is neuropathic. So this is a mixed type of pain. So whenever we have mixed type of pain, remember your medication should include both nociceptive and neuropathic medication. So you should be including your pregabalins and gabapentins and tricyclic antidepressants and duloxetins in your prescription when you prescribe medication for cancer pain. I'll also give you a typical prescription that you would use in cancer. Now, whenever you're seeing these patients, now remember, by the time they have come to the pain clinic, this patient has undergone a bit of treatment. They have obviously seen the medical oncologist, surgical oncologist, radiation oncologist. They are pretty depressed because however much you try to hide it, they know the outcome and they may know that they may not have too much time. And also they've had a lot of financial strain, emotional strain, and the family as a unit is suffering. So treat these patients with some empathy, have a chat with the other family members also, and make sure you provide some sort of supportive care along with the cancer pain treatment as well. Now, it is not a single stop solution. Now, what you have to do is whenever you see cancer patients, it is not like you're going to see these patients once and treat them and that's the end of treatment. Some of these patients after treatment are going to go into remission and then they may go into cure. There is one group which may go into remission and they may come back with relapse, right? So you're going to have both groups. So that means you will have to assess these patients periodically and depending on how they are progressing, you may have to change your course of action. So what will be a good idea is start them on a basic set of medication, reassess them after 2 weeks or 4 weeks. And then if the medicines that you have given are inadequate and they are having still pain, you have to increase the dose. If the same medicine that you've given you is saying, these patients are saying no pain, but they are sleeping throughout the day, that means you have to reduce the dose. So you have to titrate the dose as you go along because the course is going to change. So the treatment that you're going to give has to be disease directed. It also has to be patient and family directed. So always make sure you have a chat with the caregiver, whoever is coming with the patient. It could be a spouse or a partner or a parent or whoever is coming with the patient. Now, whenever you're treating with cancer patients, the most important thing is mixed type of pain. So the magic word here is mixed type. So cancer pain is the prototype of mixed type of pain. So always give medication for both nociceptive and neuropathic pain components. One. Second is there is this component which is called breakthrough pain. So that means whenever you're prescribing medications for cancer pain, other than the cocktail of medicines that you're usually giving, there has to be a set of medicine which is SOS basis or as required basis. So whenever you're giving a medicine for breakthrough pain, you need to give one SOS medicine which you need to tell to the patient or to the attender which they may take. Now, most of the time, one of the guiding principles of cancer pain treatment is you don't want to be treating these patients in the hospital. So as much as possible in cancer pain, try to send these patients home, because if these patients are not undergoing any active oncological treatment, it is better that they spend their days at home and recover, or if it is terminal, they spend their days at home, because most of the time, if these patients are palliative or terminal, you're not going to achieve anything big time by keeping these patients in the hospital. So one of the guiding principles is you want these patients to be at home. So that means your medication should be concentrated on oral tablets and on transdermal preparations. The injectables, the IMs, the IVs, the infusions, the intrathecal pumps are okay, but you don't want these patients to spend their last days in the hospital or in the ICU where you're not going to achieve much. So concentrate more on sending these patients home. That means you should concentrate on oral medication. Maximum you can think about is transdermal preparations. Now, when you see these patients, you need to have some sort of assessment of the pain score. So sometimes it's a good idea to have what is called a pain diary. So sometimes we use pain diary for non-malignant pain. It is also a good idea to use pain diary for a malignant pain. So when we use the pain diary, basically the patient jots down which part of the day they're having more pain. They may have pain only during the morning when they take bath, or when the dressing is done, or when the tracheostomy tubes are changed. So if you have an idea at what time the pain is hiking up, you can actually adjust your dose in such a way that you've given a dose, let's say 1 hour before the pain actually starts. So you can actually titrate the dose based on the duration and type of pain and at what time the pain is happening. So broadly, I told you, you are going to be concentrating with the team. So your concentration is not on curing the cancer. You have left that job to the oncologist. You're concentrating in cancer on treating cancer pain, right? So what you're doing is essentially palliative, right? So in terms of medication, the most important set of drugs that we are going to give are opioids and other medication. So when I say other medication, this would include drugs like paracetamol. We can give drugs like COX-2 inhibitors or NSAIDs. There is also a big role for neuropathic pain medicine. So neuropathic pains include the pregabalins, gabapentins, amitriptyline, nortriptyline, and duloxetine. There is also a bit of supportive medicine which you will give, which includes drugs for constipation, the drugs for anti-emesis, and so on. Now, usually these drugs are titrated according to the WHO pain ladder. We'll see about that. And in terms of interventions, we can do sympathetic blocks. Sometimes we do normal sensory nerve blocks. The advanced pain interventions include vertebroplasties, intrathecal morphine pumps, and stuff. Obviously, you're going to give supportive care to these patients. The WHO pain ladder. So the WHO invented the pain ladder essentially for cancer pain. We started using this for other pain as well. So basically, this has got 3 steps, right? So the step 1, if you're putting these patients are having mild pain. So when I say mild pain, in the pain score of visual analog score or numerical analog score, we are looking at something around 1 to 3. Moderate pain is 4 to 7, and severe pain is 8, 9, 10. So in mild pain, you can put these patients on non-opioids. So when I say non-opioids, we are talking about drugs like paracetamol. We are talking about drugs like COX-2 inhibitors and NSAIDs. Along with that, you can give adjuvants, which could include neuropathic pain medicine or supportive care, plus or minus supplements. You can give your vitamin supplements, calcium, B complex, iron, all that. The step 2, which is moderate pain, which is between 4 to 7, you're going to give mild opioids. So in India, mild opioids are drugs like tramadol, tapentadol, along with the previous set of medication. The step 3, which is severe pain, is 8, 9, 10. In this group, you're going to give strong opioids. So when I say strong opioids, we're talking about drugs like morphine and fentanyl. So in India, we don't get too many opioids. So when I say mild opioids, it's tramadol and tapentadol. When I say strong opioids, it's drugs like morphine and fentanyl in various forms, not only oral, right? And if these patients you're not able to control the pain with this medication, you're thinking about next step, which is advanced pain management, which could be sympathetic nerve blocks, which could be intrathecal pumps, vertebroplasty, even surgery or radiation, right? Has got a few rules. That is, you have to use it by the mouth. So I told you the cornerstone of cancer pain management is you want these patients at home. That means oral medication are more suitable. So you have to give it by the mouth. The second and most important rule is by the clock. So a lot of times we give morphine based on, the morphine is usually going to be working for about 4 to 6 hours. So we are going to time these patients. So usually whenever you write morphine prescription in cancer patients, it's always a good idea to tell the time at which you want them to take the dose. If these patients become smart, let's say you've given 5 milligram at 7 a.m. and 5 milligram at 11 a.m. and the next dose is at 3 p.m. The patient says that at 11 a.m. I don't have pain and I skip the dose, that is not going to work. So you have to insist that the system works if they take it by the clock, whether they have pain or not. The same 5 milligram, if they take it once the pain comes, may not work and you may have to use another 5 milligrams. So that means they have to stick to the clock and also go according to the ladder. Obviously, you have to give some attention to detail in terms of dosing the patients. So the type of medication that we are going to talk about here are paracetamol. COX-2 inhibitors and NSAIDs have a role. So when I say COX-2 inhibitors and NSAIDs, they have a role mainly in initiation. So when I say initiation, the first 4 or 5 days of cancer pain, you may be using COX-2 inhibitors and NSAIDs. We are not looking at long-term use of NSAIDs or COX-2 inhibitors. In long-term, we are looking at using drugs which are primarily based around opioids, right? So strong opioids, weak opioids, injectables, that's your long-term medication. Along with this set of medication, you're also going to be talking about steroids, which could be dexamethasone or methylprednisolone. Neuropathic pain medication, we talked about the gabapentinoids and the tricyclics and the antidepressants. And bisphosphonates and radionucleotides have a role in bony pain. So these are the top type of medications we normally talk about. Now, I told you this is a mixed type of pain and it is a chronic pain. So always remember, the prescription should be multimodal. So don't concentrate only on one type of medication. Make sure you have different types of medication in reasonably accepted doses so you get some amount of synergistic effect of all of these medications. Now, typically, all of these opioids are available. In India, we are left with morphine. Hydromorphone is not available. Oxycodone, I'm told, is coming. I don't think it's come to India yet. Methadone is available and Pethrin is available in injectable form as well. So mainly, we are left with oral morphine. That's your cornerstone of cancer pain treatment. Now, whenever you are looking at these medications, so these things you want to keep in mind. Constipation, so this is going to be there. So there's no way you're going to get around constipation. So whenever you find patients who are on opioids long-term with high doses, so when I say high doses, sometimes in my practice, since I do exclusive pain practice, it's not very uncommon in my practice to find patients who are on 200 or 300 milligram of morphine orally per day. So it's pretty common. So I'm comfortable up to 200. Once I cross 300, I may think about an intrathecal pump. So when I say 200, I've reached that dose gradually over a period of time. So constipation is something that you're going to see. So first thing is reassure these patients that constipation is acceptable. Obviously, you can use stool softness. So we are talking about mainly lactulose-based stool softness. The syrup Dufelax are a good idea. We are not too much fond of liquid paraffin-based stool softness. Next, we can give laxatives. So laxatives are available in India as the Dulcolex tablets or Dulcolex suppositories. So these ones, if you're taking the tablets, you need to take 1 or 2 tablets the previous day and night. If you're taking the suppository, you're supposed to take it at 6 or 7 a.m. the next day morning. The next option is obviously enema, which either after some time the patient can administer themselves or the aide or the nursing personnel are doing it. The final option is digital evacuation. So all this you will do. So usually for 3 days or 4 days, if they don't pass motion, we are not too bothered. Once it crosses 4 days, you need to be taking action. Almost always, most of these patients will be on lactulose syrups. Nausea is something which is pretty common in a group of patients which we call as opioid naive patient. So which patients have nausea and vomiting is very difficult to predict. So as a rule, whenever we start opioids, it's a good idea to start a dose of ondansetron 4 milligram BD for the first 5 days. So you start all patients who are you're starting on opioids, give them ondansetron 4 milligram BD for the first 5 days. After some time, it becomes SOS. So initially, always cover them with ondansetron. After some time, the ondansetron can be SOS. It's possible some patients are not tolerating opioids or one category of opioids. Tramadol is notorious to cause vomiting. So you'll have to change to another opioid. Drowsiness and confusion is something that you will see, especially in elderly patients with low proteins, emaciated patients. So if the patient is too drowsy or the patient is so sleeping that they're not getting up for eating their food, that means you have to reduce the dose. Now, one combination in patients who are on long-term morphine is patients with morphine and hyponatremia is not a good combination. So both hyponatremia and morphine can cause some sedation, and so that's a dangerous combination. So whenever somebody calls up and says you have prescribed morphine, which she's been taking it for 1 month now, suddenly she's drowsy, you ask them to check sodium in the lab that is nearby. Pruritus is not so common in oral tablets. Injectables, I'm sure all of you as anesthesiologists have seen. So you're looking at treating them with antihistamines. I've used even propofol to treat pruritus, sometimes even IV steroids. Respiratory depression, luckily, is not so common. We don't see that too commonly, especially patients with severe, patients who are on severe pain never have respiratory depression. So if you're a patient, you're suspecting respiratory depression, you need to watch out in reducing the dose, right? And also remember that whenever you're looking at respiratory depression, and if you're using something like a naloxone, remember the naloxone works for about 2 to 3 hours only. So if you are used a long-acting injectable opioid like morphine, and if you have used naloxone, the naloxone will work only for 3 or 4 hours, and the respiratory depression may come back. So you want to be keeping a close eye on these patients. Now, we talked about oral route. There are multiple routes, obviously, that are available. So if you see morphine can be given in all of these routes. So oral is one option, rectal. So oral and rectal doses are comparable. As you keep going down the slide, the efficacy of the medication keeps improving. So oral and rectal doses are similar. Then you have subcutaneous and IM, who again have a similar dosing. So the subcutaneous or IM is more efficacious than oral or rectal. Then you have transdermal, then you have IV, then epidural, then intrathecal. So obviously, the intrathecal is the most efficacious route compared to oral. So if you see the dosage of morphine that's required, as you keep going down, will keep reducing. So if you see 1 milligram of intrathecal morphine is equivalent to 10 milligram of oral morphine. And as you keep coming along, 1 milligram of intrathecal morphine will come to somewhere around 200 to 300 milligram of oral morphine. So that's why I said, whenever the patients cross 300 milligram of oral morphine requirement per day, we try to switch to intrathecal. Now, if you're in a country where a lot of opioids are available, then you need to do what is called morphine equivalent. So you need to convert to morphine equivalents to see how much the patient is taking. So on an average, Indian patients can tolerate somewhere around 200 milligram of morphine. If your patient is very small build, don't go up to such high doses, right? So the starting dose is only 20 or 30. As you keep going along, you can increase the dose. Now, I've found patients who are in the western part of the world, Caucasian patients, tolerate much higher doses. A lot of times in the US, you'll find patients who are tolerating 1,000 to 1,000 and 1,500 milligram of morphine equivalents comfortably. I know patients who are on 1,500 milligram of morphine equivalents who are going to work. Okay, so not staying at home. So the Indian patients don't tolerate opioids that well as Caucasian patients. So 200 to 300 is a comfortable dose. I'm saying about upper limit. Now, depending on which one you are using, you need to be converting. So if you see the subcutaneous dose is half as effective as the IV dose. You also have transdermal preparation. So a little bit about transdermal preparation. So in India, there are 2 drugs that are available in transdermal use. One of them is buprenorphine. So buprenorphine is available as 5, 10, and 20. So 5, 10, and 20 is actually 5 microgram per hour, 10 microgram per hour, 20 microgram per hour. Buprenorphine, this patch can be kept for a duration of 7 days. To tell you the truth, buprenorphine patch doesn't have too much efficacy. So we don't use it in cancer pain that much. We mainly use it in fibromyalgia, osteoarthritis of the knee and stuff. So other than this patch being there for 7 days, it's not such an efficacious drug. So to tell you the truth, I don't like buprenorphines at all. Fentanyl is available. So fentanyl is effective. So right now you have 12.5, 25, and 50 microgram per hour of fentanyl. So fentanyl is a good option. Now, fentanyl patches can be kept for about 3 days. So you want to be sticking these transdermal patches in a non-hairy region of the body. So usually the shoulders, upper chest, or the back is a good place to stick the fentanyl patches. So what will be a good idea is at the end of 3 days, you put the second patch on. So there is a bit of overlap of the second and the first patch. And then after 12 hours, that is 3.5 days, you take out the first patch. So that sort of works. A lot of times, the fentanyl can also be given in patients who are at home. Epidural and intrathecal, obviously, from infusing from outside, you can't do for more than 1 week to 2 weeks. So mainly we are looking at intrathecal pumps. That would be a good idea. And as you know, as anesthesiologist, depending on the route, your bioavailability is going to go up and come down. So you have to dose according to the route and the amount of drug that you are injecting. Whenever you're giving patients not on opioids, you need to be watching for liver and renal side effects. So in patients with hepatic insufficiency and renal insufficiency, you will go low on the medication dose. Now, this is a typical cancer pain prescription that I give. So let's say a patient you're going to see is reasonably emaciated. So we're talking about something around 40 kilos of weight. So sometimes these patients may also have hypoproteinemia. So a safe starting dose of morphine in India would be 20 milligram per day. Okay, so if you're giving 20 milligram, you get 10 milligram immediate release tablets, you get 10 milligram sustained release tablets. So the way I would do it is, I would start 5 milligram, which is half a tablet at 7 a.m., half a tablet at 12 noon, half a tablet at 5, and half a tablet at 10 p.m. So this is your standard dose for a 20 milligram per day dosing. Obviously, 5 milligram is SOS. Along with this, I told you it's a mixed type of pain, so multimodal. So you can give paracetamol, you can give gabapentin, you can give ondansetron, and maybe something for constipation as well. A patient who is reasonably well built and who's, let's say, 60, 70 kilos and there is no renal or hepatic compromise, you can start with 30 milligram per day dose. So when you say 30 milligram, the night dose can go up to 10 p.m. and obviously 5 milligram is SOS. So always give SOS as 5 milligram. And you can, along with the morphine, you can give paracetamols, gabapentins, ondansetrons, and the laxative syrups. So these are your typical morphine prescription. Right. So I told you the magic trick here is multimodal. So along with the morphine, you're also giving gabapentins and paracetamol. So you're taking care of both nociceptive and neuropathic pain. The role for NSAIDs or COX-2 inhibitors is not in maintenance, mainly in initiating. The first 4 or 5 days, you can start COX-2 inhibitors along with the proton pump inhibitor and then settle down at this prescription. Now, morphine is a regulated medicine. So whenever you're giving morphine, you need to put the patient's name, UHID number, the patient's diagnosis, what the reason why you have given, your name, your registration number, your seal, and the date. So morphine is available in a few regulated pharmacies, which you can use. Now, when you're talking about interventions in cancer pain, mainly we are looking at patients who are having severe pain with limited life expectancy and well-localized pain. Now, the truth of the matter is, in cancer pain, it's very dicey to do interventions because a lot of times when you do the intervention, let's say they come in with an upper abdominal pain, and after some time, this patient, you have done a celiac block, they settle down, and then they come back with a lower abdominal pain. So think twice before offering interventions in cancer pain, right? Because you'll never get 100% relief. And second is, a lot of these patients may also be having metastasis. So there may be other things going on as well. So think twice before offering interventions in cancer pain. So we'll just have a glimpse of what are the interventions that we do in cancer. So we can do local anesthetic plus cortisone injection. So that is safe. If you're not having any hi-fi facilities, if you're in a government hospital, that is safe. Only thing is you'll have to repeating these blocks. So whenever I say interventions, it is given that these procedures are done under image guidance. You have to use fluoroscope or ultrasound guidance to do these blocks. There is no role whatsoever for doing blind blocks in cancer pain. Image guided blocks with full monitoring, IV line, consent, ECG, NIBP, SpO2 monitored, and post-op monitoring is also done. So all this is already given. So local anesthetic with steroid blocks are a good idea. Chemical neurolytic agents we use, RF ablations, and advanced treatment. Now, in my practice, when I started practice, they said most of these patients may not live for 6 months or 1 year. So there's no role for doing RF ablation. So do chemical neurolytic blocks. So chemical neurolytic blocks, if I do with alcohol, this block will work for, let's say, about 6 months or 7 months or 8 months. Now, what I found in my practice is the chemical neurolytic blocks do work well. But what I found is, at least I practice in Chennai. So what I found is this patients having limited life expectancy has gone out of the window now, because a lot of times oncologists have started using palliative chemotherapy. When I say palliative chemotherapy, they give tablets of chemotherapy. So these drugs actually control the cancer growth quite well. And so a lot of these patients are not going to have limited life expectancy. A lot of times, so I do find patients who have done an alcohol block, it worked, and they come back after 6 months or 7 months and say the block wore off now, so we have to repeat the block. So at this point of time, in my practice in Chennai, I'm not very fond of chemical neurolytics. I'm more in terms of RF ablation, which is the radio frequency ablation, which may work for 1.5 years to 2 years. So that is probably a little bit better than chemical neurolytics, right? Okay, so what are the options that we have in terms of neurolysis? So we have these medications, absolute alcohol, phenol, and glycerol, which are the commonly used chemical neurolytics in India. You have RF ablation, which is a thermal ablation, and then you have cryoablation. So absolute alcohol is available easily as 100% alcohol. The therapeutic range is somewhere between 50 to 70%. Always do a diagnostic block whenever you are going for any type of neurolysis. Alcohol causes extreme pain on injection, so you want to give sedation and local anesthesia. It is not a very forgiving neurolytic agent in the sense that if inadvertently it goes into the spinal cord, epidural space, intrathecal space, potentially it can cause paraplegia or quadriplegia. Expected duration of relief is 4 to 6 months. And during recovery, these patients can have alcohol neuritis. So that means you have to be careful with alcohol, but still my preferred chemical neurolytic of choice is absolute alcohol, mainly for this 4 to 6 months, so which is much higher than phenol. So the duration is better with alcohol. So I use alcohol all the time whenever I use chemical neurolytic. Phenol is available as 12% phenol. So the therapeutic range is anywhere between 4 to 9%. You have to prepare it with phenol crystals. There is no pain on injection. Phenol can also be mixed with contrast agent as you inject. So you can see in continuous fluoro. It's much more user-friendly than alcohol. The problem with phenol is you have to prepare it, which is a big problem. And second is the duration of relief is only 3 to 4 months. So it is not as long as alcohol. So to tell you the truth, in my practice, I hardly use phenol. There is also glycerol, which we use exclusively only in trigeminal pain. So the neurolytic blocks are okay, but they're not, if your patient is going to be which is what is expected, very limited life expectancy. Off late, we don't find too much at all. So at this point of time, I'm switching more towards RF ablation. So whenever you're doing an ablation, always do a diagnostic block, again, image guided. So the diagnostic blocks proves 2 things. One is the nerve that you intend to block is indeed in that place. Second is to realistically know the outcome. So the diagnostic block is a good idea. So what are the specific blocks we do? We can do peripheral nerve blocks or sympathetic blocks, depending on which part of the body. I told you sympathetic blocks are a better idea because I told you the vasodilatation helps to take care of the ischemia. And also sympathetic block also has some effect on neuropathic pain. So sympathetic blocks are preferred over sensory nerve blocks or somatic nerve blocks, right? So just a little bit of blocks that we do. So in the head and neck, we do see patients with cancer. So in India, the most commonest is oral cancer because as a nation, we use a lot of PAN. So oral cancers, tongue, cheek, throat, base of mouth. So those are the areas that we see commonest cancers. So trigeminal is an option that we can do. So trigeminal is a block that I do routinely, very commonly for trigeminal neuralgia. So you can see my images here. So the ones on the image in the right side are usually routinely done by me. So this is a patient who's undergoing RF ablation of the trigeminal. So you can see the needle is getting into the foramen ovale here. So this is the submental view, and that's the lateral view. So this is something that I routinely do. But having said that, in cancer, the trigeminal is not a great idea for head and neck cancers. The stellate is a better idea because that's a sympathetic block. So for the face, somatic blocks, trigeminal is a good idea. In the neck, we also do glossopharyngeal. So in the base of the tongue, cheek cancers, glossopharyngeal is a good idea. On a glossopharyngeal block, you have to hit the styloid process and the glossopharyngeal nerve is behind it. A glossopharyngeal is a little risky block, so you have to be a little careful here. So a better block is actually the stellate ganglion block. So the stellate usually do fluoro or ultrasound guided. So the stellate ganglion is situated somewhere around C7, transverse process. The longest coli muscle is on top of the C6 transverse process. Your stellate ganglion in ultrasound is posterior to the carotid and on top of the longest coli muscle. So there is a pretracheal fascia. So you need to enter the pretracheal fascia and deposit the medicine, preferably at C7 level. In the thorax, you are going to be doing thoracic sympathetic blocks, intercostals or paravertebral blocks. So the easier things to do is intercostal if it is only along one side, 2 or 3 dermatomes. The paravertebral is a good idea. Now paravertebral, again, you can't do neurolytic because it's a plain block. Thoracic sympathetic, usually we do at T2 or T3 level. So thoracic sympathetic is something that we can do for lung cancers, either usually this is done unilaterally. So the stellate ganglion, the patient is supine. In thoracic sympathetic, the patient is prone. We do this fluoro-guided at the level of T2, T3 level. So this is thoracic sympathetic. Coming to upper abdomen. So upper abdomen, when I say these are organs that are coming from the foregut, you have two options. One is to do the splanchnic or the celiac. Now, the splanchnic plexus is basically a set of sympathetic nerves that arise from the thoracic sympathetic ganglion itself. The mesenteric ganglion, the aortorenal ganglion combined to form the celiac plexus. So you can block it either above the diaphragm in the thorax. So this becomes retrocrural behind the diaphragm, or you can block it at the level of L1, which becomes anticrural. So splanchnic plexus is done at T10 or T11 or T11 and T12. T11 is a good idea. Celiac is done at the upper level of L1, right? So both are sometimes done interchangeably. So probably in my practice, splanchnic is a preferred block because celiac is a scattered ganglion. You can only do chemical neurolytic here. In splanchnic, you can do chemical neurolytic and RF ablation, right? So you can see these are the images from my clinic here. So this is the image on the left is at the level of T11, 2 needles along the vertebral margin. So this is T11. You can see the lung shadow on the left side top here. The same patient, this is an AP view. So you can see the rib is at T11. So my needle is at T11 level. So 2 needles on either side of the vertebral body. And you can see the contrast here. So this is a T11 splanchnic plexus neurolytic block. The lung shadow is above. So this is T11 splanchnic plexus. This is a celiac plexus block. So this is, I've done it at L1 level. So I've come from the left side. You can see the contrast is spreading in front of L1. The same patient has got celiac lateral view. So you can see the needle tip in the right side image. The needle tip is 3 or 4 centimeters in front of the anterior vertebral margin. So this is a celiac neurolysis. So let's see, you can see the contrast spread here. So this is L1 celiac plexus block, contrast in continuous fluoro. So you will see the contrast is also pulsating. That is because of vertebral artery there. I'm sorry, the aorta there. So this is aortic pulsations that you see. This is the celiac in continuous fluoro. Next, for lower limb pathologies, that is leg pathologies, unilateral or bilateral, you have an option of going for lumbar sympathetic plexus. So the lumbar sympathetic plexus, usually we do it at L2, L3 or L3, L4. So these are needles coming in the upper border of L2, lower border of L3. So this is L2, L3 lumbar sympathetic. So the left one is the lateral view, right side is the AP view. For lower abdominal and pelvic pathologies, you have an option of going for superior hypogastric plexus block. Superior hypogastric plexus is done between L5 and S1. So in the superior hypogastric plexus is situated in front of L5 and S1 disc. So this is a good idea for lower abdominal, for pelvic malignancies. We also do this for endometriosis and other type of pelvic pain syndromes. So this is a good idea for lower abdominal and pelvic pathologies. Here again, because the ganglion is sort of scattered, you can only go for neurolytic block. You can't do RF ablation like the celiac. The last one is for perineal cancer. So when I say perineal, we are talking about perineal pain, anal orifice, anal carcinomas. We can also do this sometimes in conditions like coccydynia. So perineal pain syndromes, the sympathetic ganglion ends at the anterior junction of sacrum and the coccyx. So the needle needs to come between the sacrum and the coccyx, and the contrast needs to spread like this. So this is a ganglion infar neurolysis. You can also do RF ablation here. The advanced ones that we do are just like you see osteoporotic compression fractures, vertebral compression fractures, you also see metastatic compression fractures. So we can do a vertebroplasty or a kyphoplasty. Vertebroplasty is where you put the needle straight inside and put the bone cement. Kyphoplasty is you put the needle, put a balloon, create some space, and then put the PMMA cement. So this is something that we routinely offer in cancer pain. The final one that we do is an intrathecal pump. Now, the intrathecal pump is basically a small morphine pump. So we are looking at something like 40 to 60 ml of morphine. So if you see, I told you during the calculation, the 300 milligram of oral morphine is equivalent to 1 milligram of intrathecal morphine. So if let's say you want to give 1.5 milligram of intrathecal morphine, that's your daily required dose. This pump can contain 40 ml. So 40 ml, you can use 10 milligram per ml morphine or 15 milligram per ml morphine is also available. So in the US, you get 40 milligram per ml morphine, which is supersaturated morphine. But in India, you can get 15 milligram per ml, 15 milligram, 40 ml pump. So we can have 600 milligram of morphine. If your daily requirement is 1.5 milligram, we are looking at something around 400 days. So if you fill this pump and put it inside the patient, you have to keep it in the abdominal wall in the subcutaneous plane. This will work for about 1 year. After 1 year, you can refill the pump. Obviously, these pumps are programmable, so you can increase or decrease the dosage. We are looking at a cost of somewhere around 5 to 6 lakhs for these intrathecal morphine pumps. This is something that we do routinely. I do have patients with intrathecal morphine pumps in Chennai with cancer pain and metastatic pain. So I gave you a glimpse of what can be done. So work in conjunction with the oncologist, treat these patients as much as possible with at home with oral and transdermal medications. The advanced interventions have a role, but not too much of a role. Mainly concentrate on sympathetic nerve blocks than sensory nerve blocks. So in terms of available evidence for cancer pain, so this is the evidence. So there is strong evidence in inflammatory or nociceptive pain for opioids, NSAIDs. Wound pain, topical opioids are a good idea. Neuropathic pain, gabapentin, the tricyclics, the antidepressants, duloxetine have positive evidence. Autonomic nerve blocks have an evidence in visceral pain, and bone pain, radiation, and radionucleotides have positive evidence. Now, one thing that I would strongly suggest is a lot of these patients are pretty depressed. They are down emotionally. They are down financially. They have been in the hospital for a long time. So the word of advice is treat these patients with some empathy and give some supportive care and treat them with some in cancer pain. So thank you very much for hearing, and any doubts, I'm happy to answer. Thank you very much.
Thank you, Karthik, for this wonderful lecture on this cancer pain management and update. There are some queries. Actually, what is the ideal time to do such interventions in cancer pain management? Like, should we take the priority for the pain management and then give to the oncologist, or it should be like a stepwise manner that we should try with medications and then when we have to go for intervention? For example, a patient with carcinoma pancreas with severe abdominal pain, should I wait for morphine to act and then go for splanchnic nerve radiofrequency, or so should I subject him for intervention first for pain?
Right. So there are two schools of thought, obviously. So one school of thought is try medication first. If it is controlled with medication, keep them with medication. If it is not controlled, go for interventions, which is usually a sympathetic nerve block. The other school of thought is that school is based on the theory that once the metastasis is very severe, the blocks do not work that well. So do the intervention first. Now, practically, since I've been practicing in Tamil Nadu or in Chennai, what I found which is useful is the blocks are really your plan B or plan C. So I'm not very fond of cancer pain blocks, even though I do offer them, because one, Unlike nerve blocks, interventional pain management procedures, which you do for spine or joint-related problems, you won't get very high percentage of results in cancer pain. So at best, we are looking at 70% relief or 60% relief or something like that. One. Second is very common to find patients, let's say they come in with the cancer pancreas and you have done a very successful splanchnic block. After 2 months, they come and say the upper abdominal pain is gone. Now I have pain in the lower abdomen because there is a midst there or a shoulder pain. So you can't keep doing multiple blocks in multiple places. So blocks in cancer patients are okay, but I am not very fond of them. So my way of doing it is I will try oral treatment first, conservative treatment with medication, transdermal oral medication first as much as possible. And only if it is desperately required, I will do the interventions. That's my way of doing it.
So in your practice, what do you find as an obstacle for pain management in cancer patients? So what type of obstacles do the patients have? Because they are not straight away referred to the pain physician first. So what are all the obstacles for the pain management?
Okay, so there are two ways of doing it. Now, to tell you the truth, when I started my pain practice, I finished my training, and then I came and met a few doctors and said, I do pain, and I met orthos, I met oncologists, I met other people. Now, what I found surprising was none of the orthos or the other physicians referred patients to me, but the oncologists readily referred patients to me. So I found that very surprising. And to tell you the truth, the beginning of my pain management practice was more oncology based. I did a lot of cancer pain blocks. Now, that is good. Two problems here. One is treating only cancer pain as a full-time job takes some amount of toll on your emotional and mental well-being, because very difficult to do practice without getting reasonably involved with these patients. And these patients, one, they have suffered, they have been in hospital for a long time, the family is depressed, the patient is depressed, the patient may know they are going to die. Financially, they are down, they have taken a loan, they have sold their house, they have sold their farm. So they are in a really bad situation. And also, from a business perspective, when you do the practice, when you see these patients, you have seen a patient. So normally, let's say I charge so and so amount for a block. And in a patient who's really depressed, who's taken a loan, very difficult to charge for your procedures also. So there are multiple problems here. So the truth of the matter is, this is my individual perspective. In my initial days, cancer pain was a big chunk of my pain management practice. Right now, it's probably 10% or less. And these patients also, they come by themselves. I don't go advertise saying that it is cancer pain. I do mainly cancer pain. So if you look at my brochures, the cancer pain is the last line. So it's a little tricky to practice, but probably only to do cancer pain if you are part of a hospital where you are being paid irrespective of your practice, that may be a good idea. Practicing outside standalone pain clinics doing only cancer pain may be very difficult.
Is there any specific contraindication for interventional pain management in cancer patients? Like, say, for example, you talked about Gazarian ganglion block in patient with carcinoma buccal mucosa. So I have a fear that if I put the needle there into the oral cavity, needling and taking that metastasis to the brain, so is there any specific contraindication and issues related to that?
Now, there are two types of problems in doing a trigeminal in a patient with oral cancer. One is there is a cheek lesion. So there is a lesion, let's say the cheek, and the needle has to go from the cheek, right? So one is it may bleed, first thing, because you are going through the lesion, which is not ideal. So there have been times when I have kept pressure on the lesion for about 2 hours or 3 hours also. Second is this fear of metastasis is not something that I break my head about, because this is referred by the oncologist, so they know this lesion is there. What is actually worrying is I have found patients who have had lesions in the cheek or pain in the face where I have done the trigeminal, either neurolytic or RF ablation. Now I have blocked the sensory component, right? Now, a lot of times, because it's a bony cavity and the lesion is going, the pain in cancer, in the head and neck at least, is caused because of pressure effect. right? So because the surrounding fascia is being stretched. Now, what I have found is you have a lesion in the face, you have done the trigeminal, the trigeminal is working. The patient may come back to you and say, I am numb, which is your intention of doing the block, but I still have pain. So this is because this is neuropathic pain. Okay, so that being the case, you will not get great results with trigeminal in oral cancers. One is it may bleed. Second is remote chance of metastasis. Third is it may not work that well. So in head and neck cancers, it's better to do a diagnostic stellate and concentrate on stellate than trigeminal or glossopharyngeal.
Okay, because you're emphasizing again on the vision of diagnostic block, how much this diagnostic block is going to be helpful in a cancer patient, because already they are suffering with severe pain. Should I do every time? Should I do for diagnostic block and then go for neurolysis, convincing them for chemical neurolysis? That is better, or should I straight away go for chemical neurolysis, understanding the pathophysiology of the pain from the particular patient?
Now, two things here. One is when you do the diagnostic block, see, by most of the textbooks, if you read, whenever you are ablating, when you say ablating, chemical ablation or RF ablation. So whenever you are doing neurolysis, you're destroying a nerve, you need to do a diagnostic. That's the rule. Now, the diagnostic gives you 2-3 things. One is how much realistically will be the outcome. So if the patient says my original pain is 100%, after the diagnostic, 80% of my pain is gone. It is anything of this positive diagnostic. So if they say 80% of my pain is gone, you are reasonably confident that the subsequent neurolytic or RF ablation will produce at least 60%. One. Second is diagnostic is all the more important in cancer pain because the anatomy is altered. So you only know this nerve is supposed to be beside this bone. You don't see the nerve a lot of times when you're doing especially STA procedure. So that nerve may not be there. So when you do the diagnostic, it also gives you an idea about the location of that nerve. So if the diagnostic is positive, likely that nerve is there. So the RF ablation or the chemical neurolytic will work. So diagnostic is actually a very good idea and I would recommend it. So if it is a question of charging the patient or something, you should probably include that in your package. So if let's say I'm doing a celiac plexus block, I would charge very less for the diagnostic and I'll do it on day 1 and see the response. And on day 3, I will do the actual procedures and maybe give the whole thing as a package. So there is the package includes everything. And if the diagnostic is negative, so be it. It's fine.
You talked about the glossopharyngeal nerve block. So what will be the airway? Is there any problem related to the airway reflexes post glossopharyngeal nerve block? Have you encountered any complication related to it?
Now, glossopharyngeal nerve block is not for junior pain physicians because that area is a dangerous area. So glossopharyngeal nerve block is very close to the carotid body, the IJV, the vagus is very nearby. So it's a dangerous area, right? So basically, we are looking at an area somewhere between the angle of the mandible and the mastoid, and you are going in. And hopefully you'll be able to see the styloid process. You hit the styloid process, the glossopharyngeal nerve is behind it. Now, glossopharyngeal neuralgia, you will get to do mainly when you have elongated styloid process, which is glossopharyngeal neuralgia itself, which is also called Eagle syndrome. Sometimes in cancer pain where they have throat cancers, cheek cancers, glossopharyngeal is a good idea. Glossopharyngeal will also have some effect on swallowing reflex. So never do glossopharyngeal bilaterally. Second is chemical neurolytic in the glossopharyngeal, again, is not a good idea. So the RF ablation is slightly safer because the RF ablation is a controlled lesion. When I say controlled in the RF lesion, if your needle is here, the lesion is 2 or 3 millimeters on either side of the needle. Whereas in chemical neurolytic, you're injecting a solution. The solution may go wherever there is less resistance. So chemical neurolytic in the glossopharyngeal is also not a good idea and slightly risky block, especially for juniors. So probably when you're starting pain practice, you should start with the lumbar basic sympathetic blocks. After 1 year of safe practice of all of this, then you should come to cervical region, stellates, and then finally you should come to trigeminals and phenopalatines. And in my book, probably glossopharyngeal is the last block you should try because very risky even for this experienced pain physician.
So when a patient is having trismus, how will you manage the cancer pain because that problem with oral medications and other issues?
You're saying they have restricted mouth opening, right?
Restricted mouth opening. So if they are not willing to get the nasogastric tube also in, should you go for interventional pain management first in these type of patients, or still recommend other forms like transdermal practicing?
See, there is no perfect solution a lot of times in cancer, so you have to compromise and get around the problem. So, to tell you the truth, I'm not much into palliative care. Okay, so my intention is mainly interventions, cancer pain management, oral and interventions. Now, if you are finding a patient with trismus, you have 2 or 3 options. One is nasogastric tube, either through the nose or oral. The other option is a feeding gastrostomy or a feeding duodenostomy, or injectable preparation, which could be subcutaneous or transdermal. So these are your options. Always there is a risk of aspiration in these patients. So you don't want to be force feeding them tablets which are crushed in a saline or with the juice or coffee. So that risk is also there. So think of alternate routes, which could be nasogastric tubes, Ryle's tube through the mouth, fixed Ryle's tube through the nose, feeding duodenostomies, or transdermal. That should be the way to go. And with the trismus itself, sometimes I do inject, again, it's palliative. I do inject local and steroid into the sternocleidomastoid, sometimes even botulinum toxin, which is a muscle relaxant. So I do Botox injections if it is mainly because of very tight constricture of the neck or the sternocleidomastoid. That is also another option.
Thank you, Karthik. I think we have taken up almost all the questions. And one question is related to splanchnic and celiac plexus block. I think you have already answered that about the duration of block. Thank you. Thank you for your time, spending a valuable time with us. And thanks a lot. And for all the young physicians here, we have a good role model how to treat cancer patients. Edward, sir, any other points do you want to add up?
Yes, sir. We can conclude, sir.
Okay. Thank you, Karthik. Thank you, Edward, sir. Thank you.
Thank you, Karthikbabu, sir, for extensive coverage of the cancer pain update. And also, I thank Rajesh, sir, for our wonderful discussion. With that, we come to the end of this session. We will meet next week with a still more interesting topic on intravenous anesthesia. Thank you, Ananda.
Thank you very much.